most of the time, we look at this stoppage of this jump or maybe ablation of this low pathway as a successful termination point for AV nodal reentrant arrhythmias. There are some patients who may have more than one slow pathway, where one slow pathway may be pathological while other slow pathways may not be pathological. You may have a persistence of slow pathway conduction even after successful AV nodal reentrant arrhythmia. But most of the patients, they have one slow pathway conduction, and the moment you do a slow pathway modification or ablation, you tend to see stoppage of this one-to-one conduction over the slow pathway area. So one important thing is your ablation catheter is positioned along the tricuspid immediately anterior to the CS ostium. You position your ablation catheter, go deep inside the RV, you pull it with a little clockwise movement so that you come before the CS ostium. You have to be very careful. Whenever you are going to ablate AV nodal reentrant arrhythmia, you are going to remain more ventricular than atrial. That means your signal should never have a larger atrial signals. You always, wherever you remain, even at the CS os level, you tend to see smaller atrial signals than the ventricular signals. Larger A usually says you are remaining very closer to the conduction system. We all know that your AV node is not exactly at the his area where you are recording his. That's not the area where your AV node is situated. We know AV node is an atrial structure, and this is located little below where you are recording his signal, maybe mostly towards anterior side. So when you are going to record a larger atrial signals, your possibility of remaining over a compact AV node is very high. You deliver on a compact AV node a few seconds of RF, then AV nodal conduction stops forever. So you have to be very sure that you don't remain on the atrial side of tricuspid any point of time when you are ablating AV nodal reentrant arrhythmia. RAV view is very good for positioning catheters because here you know the height. When you are in a RAV view, you clearly see where this is located and how low you are. This is the position where you will be able to see the height of your ablation catheter very easily. So I usually prefer RAV view for positioning catheter and lot of times ablation also, because looking at a LAO all the time gives you a lot of exposure. So I always keep position catheters in RAV view, check in the LAV view and come back to RAV view and ablate. So ideally you are supposed to remain in LAV view during ablation, because in the early days it's better too, because you will be able to see a smaller movements in the catheter very easily in LAV view, while RAV view may not be clearly show the smaller movements or septal and non-septal movements. So you have to remain in RAV view to position catheters. What you are looking at is an isthmus of tissue between the tricuspid valve annulus and ostium of CS. This is the area anatomically the slow pathway is located. So this is usually the location of rightward inferior AV nodal extension. What you are trying to ablate is the infra-posterior part of this area where the slow pathway is located, which is a rightward inferior AV nodal extension. So this is how your catheters are going to look like when you are going to deliver a AV nodal AV NRT ablation by modifying the slow pathway. I, in my practice, 100% use long sheets. The commonest long sheet I use is usually a Nodal sheets because they give a better stability, and second, they give a better RV entry. So staying in the ventricular side becomes easier. There are catheters which take you septally. Some people use these catheters to take the catheter septally. I don't like them because they tend to take you a little higher. And Mullins sheets usually takes you lower, which is easier for you to manipulate. If you want to go higher, always you can deflect your catheters and deflect and go up the areas which you want to ablate. While most of the other catheters like SRO or SLO will tend to take you septally and go a little higher locations. So I use sheath in every of my AV nodal reentry ablations. So you can see in RAV view clearly a coronary sinus catheters with the CS os clearly visualized. And you can also see a his bundle catheter electrogram. You see a proximal his bundle catheter, proximal part, and your ablation catheter is well below the his bundle catheter. So this is very important. This much of a safety margin is very important. You can clearly see in LAV view, your CS catheter C, which is getting into the coronary sinus, and you can see as your ablation catheter facing septally. This is very important. You face septally towards the spine. Your catheter should face that, and you know very well the septal movement of your catheters. When your catheters are moving, you should observe the movement. It should be a septal movement. They should be fixed. There should not be a movement from septal to free wall, or which is not stable catheter. The movement should be with septum, and movement of the tip should be minimal, and upward movement should not be allowed. When you are seeing during respiration or during your catheter movement, you see your catheter is moving upwards, then you should make sure that you keep catheters little stabler by pulling it down. You always pull your whole catheter assembly low and keep them clocked and kept in a very tight position so that they don't move. This catheter should always be in this location. There are a few approaches by which you can ablate the AV nodal reentrant arrhythmia. The most commonest way most of us ablate is a part of this is an anatomical approach. We know that coronary sinus in most of the patients can be dilated. So you see a coronary sinus which is dilated. So in this patient, again you could see that coronary sinus catheter is coronary sinus has been given an injection, and you could see a coronary venous angiogram. You could see a dilated coronary sinus. This is the area which we are interested, the coronary sinus ostial area, which is very closer to the slow pathway area. You can see in the LAO projection. So you can have various inputs during your AV nodal reentrant arrhythmia, and we are more interested in what we call as a right inferior input. You could see both in RMO and LAO view how it looks like. You could see in RMO view when you go just anterior to the coronary sinus ostium in the tricuspid annulus, little lower and little towards CS arse area, you can clearly see a right inferior input being located. In LAO view, again you could see that this is what I was telling you. You could see this is the safety margin you have. Your compact node is just above the area where you are ablating. If you are going to the roof of coronary sinus, you are few millimeters away from your compact AV node. So you have to be very careful. So this is the area which we are going to target, right inferior input. So this is the area where you are planning to ablate a slow pathway if you are going to look at this place anatomically. So the tricuspid annulus just outside CS arse in the inferior paraseptal region, or there are sometimes you may have to go little within the proximal segment of coronary sinus arse area to get this slow pathway. Most of the time, atypical AV left alone. Typical AV are ablated during sinus rhythm. We ablate during sinus rhythm. We use usually distal electrode, which is 4 mm, which is commonly used. We use 8 mm catheters in flutters, but always choose a smaller 4 mm catheters tip because you don't want to give a larger lesions. You can use various curves which are available with each manufacturer. You can use medium curve of Abbott or SJM or orange curve with Cardis. These are the curves ideally located for a usual AV nodal reentrant arrhythmia. There are times you may require a smaller curve. A small curve of Abbott is rarely used because it hardly reaches the slow pathway area even in kids. So we don't use smaller curves. There are times when you have a dilated coronary sinus, or there are times when you have a prominent eustachian ridge, you want to go above and come down, you may have to use a larger catheters, maybe a large curve of Abbott or maybe a wide curve of Cardis. But I don't use commonly because when you use Mullins, this problem is taken care of. When you use a Mullins catheter, you can take a medium curve catheter and even ablate with a larger prominent eustachian ridges also. So I use mostly 100% medium curve of Abbott for ablating AV nodal reentrant arrhythmia. So you can use long sheath, which is optional in most of the cases. Why I use 100%? Because it makes your life much easier. Because your catheter is very stable. You don't have to look at the catheter all the time. It gives you excellent stability, and your possibility of getting atrial side becomes limited because your catheter tend to move to the ventricular side more than the atrial side. So you can use this long sheath. As I already told you, the long sheath which I use is Mullins. But there are people reach a slow pathway, the torque which you measure is a clockwise torque. When you rotate your catheter or your sheath, the clockwise motion, you tend to move towards septally and you reach the slow pathway area. When you have a catheter alone, you hold the clockwise torque of your catheter. When you have a sheath and the catheter, you clockwise torque is given to both sheath and the catheter and kept in that motion. You have to keep the catheter touching the septal area of the slow pathway. Because this is very important, consistent touch or consistent contact is very important. If you are not keeping it hold and you are not delivering with the consistent contact, you may not get sustained junctionals. You may have few junctionals coming in between your ablation, which may not be enough. The possibility of recurrence are higher. So you have to get a good junction. For that you need a good contact. Good contact is provided by a clockwise torque. The AB ratio recorded from the distal electrode parallel sinus rhythm should be into 1:10 to 1:3. You prefer a smallest possible atrial electrogram. Both are important. You have to record atrial electrogram. If you remain on a ventricular sinus ablation, you are not going to achieve anything, although it's a safer place. If you are having maybe a 2 to 3 or 1-to-1 atrial electrogram, your possibility of getting junctions are very high because you remain very close to the cardiac system, but it's very dangerous. So you remain in between. You record somewhere between 1/10 or 1/3 of a ventricular electrogram in atrial electrogram. Your atrial electrogram at the slow pathway is usually fractionated. You don't record any sharp signals at the atrial side. If you see a sharp electrogram in the atrial signal of your slow pathway area, then you are not properly in the slow pathway area. The possibility that you are more towards annular rather than remaining septal is very high. So you try to get a fractionated atrial electrogram which is smaller. Most of the time, what I do is I get a larger ventricular electrogram and get a small atrial electrogram, and then when I get that, I go give a good clockwise torque and hold so that your electrogram remains stable. Make sure before you start your ablation, your electrograms are stable. If you see a electrogram is changing with a larger A and smaller A, that means you are moving atrial side during your ablation. That is dangerous. So make sure before starting ablation, you are remaining very stable. This is very important. This is what we are talking about. So this is how anatomically it looks like. This is the inferior isthmus which we are targeting. And we know very well your fast pathway remains antero-superior. So to a slow pathway is postero-inferior and fast pathway is antero-superior. So this area you have to avoid. Here I have shown in the anatomical diagram, you could see a eustachian valve and eustachian ridge. This eustachian ridge can be very prominent in some people, particularly people who have a incessant AV nodal recurrent arrhythmia, people coming later. This is not very uncommon. When you have a very prominent eustachian ridge, going to this slow pathway area may be difficult because you are coming from femoral vein, you are coming through this area and trying to reach slow pathway where your eustachian ridge will prevent all septal movements and will take you to the annulus all the time. So sometimes you may have to either take a sheet, go over the eustachian ridge, flex your catheter and come to the slow pathway area, or if you are only with the catheter without a sheet, then you may have to take a larger U to reach the slow pathway area. I prefer, whenever I see a prominent eustachian ridge, always a sheet because it gives you a better contact. This is the one area you have to avoid is the area where you are going to have a fast pathway which is higher. Don't go to that area. You know the CSR, you know tricuspid annulus. Go to the tricuspid annulus, come infro posteriorly and remain there with the clockwise rotation. That's the area you have to target. So again I have marked it for you. You could clearly see where you have to ablate. The slow AV nodal pathways usually got 95% cases in this area. You don't have ascent higher. Most common reason why you are not getting a junctionals during a AVNRT ablation is because you are not remaining septal. You are not going posterior, rather than you are not in the proper height. When you remain in this height and you are not getting a good junction, make sure you give a good torque and go more posteriorly rather than climbing up. Climbing up should be the last option. Going posterior should be the most preferred option. So 95% of the time, your slow pathway will be ablated when you remain in this location. So this is the if you want to see in your fluoro in both RAO and LAO view, this is where you are going to get most of your slope pathway being ablated. Sometimes, very rarely, not very commonly, so don't try this as a primary thing. You can get slope pathway in the proximal portion of CS. When you have exhausted your posterior location, you have done good posterior ablation, still you are not able to get a good junctions or AV nut is still inducible. The next area we can try is a proximal portion of coronary sinus, which is you don't go deep inside the coronary sinus, you remain at the os of coronary sinus. Here you are going to record not a very small A, not a fractionated A, but you are going to record a larger A. When you remain in the proximal CS, you are going to record the larger A. Make sure you are in the CS area because larger A's are usually avoided in AV nodal re-entry ablation. But you can remain in the proximal CS with a larger A and ablate. But here also, your A signal should be less than the V signal. You remain even at the proximal CS area. Make sure your ventricular signals are larger. There are times you may get an equal sized A and B, but still you make sure that you give a little counter clock. When you go into the coronary sinus area, you tend to see a larger A. When you counter the clock, you will just come little outside the proximal port of the CS where you will start recording a smaller A's. So you remain on the areas where you have a smaller A's. So whenever you are going to ascend up, you can see here I am trying to go up. When you go up and up, you are going to have an increased risk of AV block. So you try ablating lower posterior if required proximal part of CS before being adventurous and going up. Usually you can go sometimes deep inside the CS, particularly for left-sided extensions. There are sometimes you may have to go left side and get the left-sided extension. There are few patients who may be able to go inside the coronary sinus and ablate. When you are going inside and ablating coronary sinus, make sure your impedance is programmed in such a way that it allows you to deliver at a little higher impedance, and closely watch for dry heat. And because when you are ablating in the coronary sinus, you are ablating in the area with which lesser blood flow, you tend to produce a steam pop. So you make sure that you don't go with the higher energies, and watch closely your impedance. Any rising impedance, you have to immediately stop when you go inside the CS. I don't go inside the CS and ablate. I ablate in the proximal CS. If I don't get in the proximal CS, I feel it's a left-sided extension. I take a transeptal, go to the other side rather than going deep inside the CS. For some patients, the centers which have cryoablation may be useful, but sometimes when you are not able to ablate high up and your patients are risk averse, who are not interested to get a risk of an AV block, you can go move cephalad and reach places above the CS os. My center has cryo, but I still have not used cryo for an AV nodal re-entry so far. In the last 3-4 years since we got an cryo, still I have not ablated any single AV NRT with a cryoablation. It clearly shows you can manage most of your difficult AV NRTs also with the radiofrequency ablation with management of power settings and the anatomical locations. One thing which I always use when I have a difficult AV NRTs is 3D mapping. 3D mapping is useful for me in most of my cases. At least in KMCH for the last maybe 5 to 7 years, we have ablated most of our SVTs under 3D. I don't use fluoro-guided for few reasons. I have 3D available all the time, so I can use 3D whenever I want. And most of my SVTs are ablated in the 3D, and we have ablated close to around, maybe it's a little older data, maybe more than 600, 700 AV NRTs under 3D. I use default 3D. The time taken is very less because we use 3D regularly. My fluoro exposure is very low. You know, AV NRT ablation on its own has a very less fluoroscopic exposure, and I use fluoro rarely. So my AV NRT ablations are hardly have any exposure. So I'm showing this for you just to understand how your AV nodal re-entry looks like in your anatomical location. Because when you see in fluoro, you don't see all this. When you see in 3D, you tend to see clearly where your CS is, where your S is, and where you are ablating. You can clearly see I have given you two pictures, one showing a RA view in two different projections, little rotated, and again a LA view in two projections, little rotated. You can clearly see where I am ablating. This is what we saw in fluoroscopically. the infra-posterior location where you see a slow pathway in most of these people. So don't ascend up. Don't ascend up. The red points which are tagged in this map are his locations. So his locations are tagged. You can see in the patient, I have gone little capillary. I have moved little up, went little high, because this was a very difficult AV nodal ablation. I remained at a lower dose and went little up, which is not the case in most of the cases. You can see very clearly where my catheter is, and this is the proper location. You have a CS os. You can see in the REO projection, the CS os is seen posteriorly. I have moved little ahead of CS os in the tricuspid annulus, and you see in LAO projection, I am facing septally towards the CS os. So this is the location where you are going to ablate the AV nodal reentrant arrhythmias. So we have to keep temperature and power according to the need. I use, depending on size of Cox triangle and how I am getting the first ablation, I titrate my energy and go. Usual settings for me is a power of 60 and temperature of 60. I use this in most of the patients. If I see onset of junctions very early, maybe if I put the ablation on and junctions are coming, I usually reduce the energy. If my 60 watts and I start ablation, junctions are coming immediately, I go to 50 watts and ablate. Even on 50 watts, within 10 seconds I get junctions, I usually reduce to 40 watts again. This is the one way of doing. Other way of doing is a more safer way, which most of the books will tell you. You go with the 30 to 40 watts and ablate. If you don't get junctions, you step up by 5 and deliver again. Again step up by 5 and deliver again until you reach 50-60 watts. So this is another way of doing, a safer way of doing. I do in a reverse way because we know now after doing maybe so many AV NRTs, how to avoid complications. That's the reason we go on another way. But when you start early, it's better to go safer. So when you see clearly, you can see when I started ablating, you could see junctions coming in. You don't want fast junctions. There are people who don't allow even a junctions more than 100 beats per minute, but I usually allow at least 100 and 120 beats. But your junctions are too faster, then you stop. Then you are not ablating at the slow pathway area. Maybe you are going closer to the fast pathway area. That's the reason you are getting fast junctions. A slow pathway junction should be a slow sustained junctions. So if you get a slow sustained junctions, that clearly shows that you are in the slow pathway area. When you have fast junctions, you are at the fast pathway area or on a higher cephalad location. You bring down your catheter and deliver again so that you avoid collateral damage. So sometimes you may have to go this higher. I have gone this higher in a few of my patients where closely monitoring, I go with a very low energy. So when you are ablating AV nodal reentrant arrhythmia, this is how your power looks like, your temperature setting looks like, your impedance looks like. You have to watch all this. Your power has to be maybe reasonably stable. When you are not properly in the contact, sometimes your power oscillates between, you will see you have programmed a power of around 50-60 watts, but you will be delivering 20, 30, 40, and it will be changing all the time. That means you are in a proper contact. Then make sure you give a proper contact and get a good power, sustained power. The temperature settings, most of the time we keep more than 50 because you want to give a irreversible damage. Impedance should never rise. You are looking at a drop in impedance, but in AV nodal area, you don't have to achieve a big drop in impedance because you remain very endocardial in the superficial structure. But rising impedance is a danger zone. If your temperature is, your impedance is rising, you are giving a dry heat, you may end up in a steam pop, particularly when the areas which is not very much vascular. As I told you, sometimes when you are going to the deep into the coronary sinus and ablating, your impedance may rise. That's the time you have to immediately stop. Most of your ablators have a stop mechanism. Even without that also, you have to be very careful. If your impedance are rising, you stop. You have to monitor the impedance, AV and VA blocks. You can do in two ways your AV nodal reentrant arrhythmias. One is you deliver, you look at the junctions, follow the junctions and look at the VA conduction and follow the VA blocks. Any VA blocks, stop. Other way around, there are times you can monitor AV. What we can do is you identify the area where you are getting junctions. The moment you get a junction, start pacing the atrium at a slower rate, maybe to 500, 600 milliseconds, and deliver and follow for the AV conduction. This is another way. This I do in some patients, particularly there are some patients who come even with drugs and VA is very poor on baseline. When the patient has a very poor baseline conduction, VA conduction, when you are going to give a junctional, your junctionals are going to block at the VA level. This will not allow you to deliver a reasonable ablation. In that situation, what I do is I deliver. Once I get a VA block, I go and pace atrium, get a AV conduction on and deliver. When you get a monitor the AV conduction. Whatever we do in a VA conduction mode, in a junctional, whatever we are monitoring a VA conduction, we are more worried about the AV conduction. Basically, VA conduction basically tells you about the AV conduction. But if your VA conduction is not good because of some other reason, you can do a AV pacing and try to monitor the VAV conduction so that you are pretty sure that what's happening. You have to monitor the catheter position. You can initially use low power 20 to 30 watts and gradually increase up to 50 watts with a target temperature of around 55 to 60 for 30 to 60 seconds. Energy has to be limited when you are delivering the proximal CS to 20 to 30 watts looking at the impedance. A few lesions are usually sufficient. Don't consolidate too much. Junction rhythms are induced and not specific for eliminating AV nodal artery. So it is elicited more at a successful sites than unsuccessful sites. So one thing is about junction rhythm is if you get a junction rhythm, the possibility of getting a successful AV nodal ablation, AV nodal re-entry ablation is very high. But it doesn't mean that when you get junctional, you have done a job. If you are not getting junctionals, your AV nodal re-entry ablation is unsuccessful most of the times. But if you get a junctionals, make sure you check again because there are times you get very good junctional, even that after that your slow pathway is still there. Always look for a VA blocks. There are very, very rare circumstances where you can get a slow pathway ablation done without junctional rhythms. I see very rarely when I'm giving maybe a line from the CS OS to IVC. Sometimes I do that line in very difficult AV arteries. That's the one time I have seen that, but otherwise you always get a junctions for a successful ablation. Endpoints are your tachycardia has to be rendered non-inducible with or without isoproterenol, and elimination of A jump, elimination of one-to-one conduction through slow pathway, a retrograde VA blocks through slow AV nodal pathway if you are ablating an atypical AV artery. A jump with a single echoes can be allowed. If you have a previously inducible arrhythmia, you can leave single echoes, you don't need to do anything. If you have a fast pathway injury, your PR is prolonging and you got an AV block, you stop immediately. You get a PR prolongation which is persistent. Sometimes you get a PR prolongation because your catheters hit this area, you leave it. Otherwise, you stop. A transient AV nodal block after radio frequency. If you have delivered a radio frequency and you see a transient AV nodal block during or after AV ablation, you just make sure you stop it. Preventing AV block is very important. Direct injury to the compact AV node or fast pathway, if it is inferiorly placed, you can hit it. Damage to the AV nodal artery or a pre-existing fast pathway dysfunction. You are ablating a slow pathway and patient already has a fast pathway injury or fast pathway disease, you may get an AV nodal block. And some people can get a delayed AV nodal block. There are patients who come to us after 5 to 7 years of AV nodal reentrant ablation with an AV block. So even you remain careful. There are times you may hit the AV conduction area if your AV node is posteriorly located or you have an AV nodal artery very closer. This happens when you are ablating inside the coronary sinus because that's the area you are going to see the AV nodal artery. And there are patients who can develop an AV nodal block later also. The safer zones, the green ones, I have given you in a LAO view. The green ones are the safer area, RAO view, sorry. Green ones are the safer areas where you ablate the AV nodal reentrant arrhythmia with the slow pathway modification. Yellow ones are okay, but red ones are strict no. You don't go into the places where red is marked. That's the area where you are going to hit the AV nodal conduction system. Close attention to the retrograde conduction is very important. I told you about pacing the atrium when you have a AV block, VA block even at a very low energy. That means some patients can have a persistent VA blocks which may not allow you to give a good ablation. There you can use AV. Rapid junction rhythms with cycle length less than 350 is strict no. You don't allow this because there is an impending AV block which is going to come in. So you can see the catheter movement here. This is the catheter movement you are seeing. I am not using any sheath. Your catheter is moving too much. You can see it is coming to the atrial side very easily. And you can see I'm using a sheath here. I have gone with a sheath. Your catheter movement comes really minimal. See, with a catheter movement, most of your movement is septal, is going along the sheath. while without a catheter, your catheter was getting into the atrial area, which is dangerous. Tips, always stay low. At least in the initial part of your career, maybe initial 3 to 5 years of your EP career, always don't cause AV blocks. Stay low. Ablate with larger V's. Ablate always with the larger V's. When you are going to the higher sites, when you are moved to the LA areas which I have shown you, go with the lower powers. Go with the 20 or 30 watts rather than the high power. When you are not able to ablate with the safer junctions, or sometimes you are not able to monitor junctions very clearly, go in pulses. You given a 10-20 second pulses, monitor, because in the early days it may be difficult for you to monitor. There are times when we may not have a good technician who will be monitoring your VA conduction. You are the person who have to monitor, and you are the person who have to ablate, you are the person who is going to monitor the fluoro. So in that times you go with the RFA in pulses, which is very important. Careful monitoring of VA. VA is a reflection of your AV conduction. Any VA block, don't go. If you get a single VA block, also stop, then redeliver rather than allowing VA blocks. There are people who tend to allow VA blocks thinking that this may be a poor VA conduction, but don't assume anything. If you get a VA block, stop. Stable catheter is paramount importance. Paramount importance. You use a sheath if required and keep your sheath very stable. Septal IVC lines, sometime I use, very rarely used. Maybe in the last 15 years, I would have hardly given 2 or 3 patients a septal IVC line, where we draw a line from the CS source to the IVC in a very difficult, incessant aviodontal reentrant arrhythmias. I would say I have done this, but I have not done this after I started using a 3D mapping, because after 3D mapping came in, I used to go little cephalon also, little in a safer way. So I don't use this line anymore. No adventures. Aviodontal arrhythmia is not a killer arrhythmia. It's not a malignant arrhythmia. Your patient is not going to die of an aviodontal arrhythmia. You deliver safer, and if you feel like your ablation is not adequate, and if you go cephalon, you are going to cause AV block, come out and tell your patient that this is a risky area. I have a narrow Cox triangle. I've ablated whatever I could. If it recurs, I will do it again. That's no ego, nothing. You can always come back again with a prepared patient. A patient who is not prepared for an AV block is dangerous. When you go in and cause an AV block on a patient who have already not been tuned or is not talked about an AV block, you just call and tell them tomorrow morning I have to do a pacemaker. It's a really difficult thing. So always not be adventurous in your first attempt. Even in a patients whom you felt that you are not completely ablated the slow pathway area or modified the slow pathway area, you would see the patient not having a recurrence at all. I have seen, maybe sometimes I come out thinking that I have not given a good slow pathway modification. That patient have not come to the come with a recurrence at all. So there are times you will feel during the ablation that you have not done a great job, but still you might have got the slow pathway done. Rather than going cephalon and causing AV block, you keep yourself ready for a second ablation if required, rather than going very adventurous. The most easy way is, whenever you have a problem, verify your diagnosis. Is it a AVNRT? Improve the contact. If required, change the catheter. You can move on to a 3D mapping if you have. Use a sheet. You look at the alternative sites like the proximal CS or left-sided ablations. Going higher should be the last option, at least in the initial part of your career. Look at the differential diagnosis, focal junctional tachycardias, or AT coming closer to the junction, AT coming from the low tricuspidalus or a septal axillary pathway or nodovascular pathways. These can mimic a aviodontal arrhythmia. If you have a problem in ablating slow pathway, make sure that you made a proper diagnosis. So there is a full list of what to do when you have a problem in ablation. When you have a difficult-to-induce AVNRT, you can sometimes modify the slow pathway. If you have a dominant ECG, poor catheter stability, a prominent eustachian bridge, use long sheath with a septal angulation or a Mullin sheath. You have a prolonged AH interval before ablation itself, then ablate the retrograde fast pathway is difficult. In that case, you may use a cryoablation, and you be advise the patient about the AV block. No junction rhythm about during an ablation. Maybe a poor catheter contact. Use a sheath or give a good clockwise start. A change to a different form of AVNRT. There may be multiple slow pathways. Then you may have to ablate a retrograde slow pathway, sometimes both right and leftward. VA block during junction rhythm, you are very closer to the compact AV nodal area, avoid that area, ablate inferiorly, bring your catheter down. Non-specific endpoints, poorly inducible tachycardia, absence of a dual AV nodal physiology. You access for the modification of slow pathway function. You look at the Venki back. If there is no crossover, you're not inducing with a high dose of isoprene. I think that should be good enough rather than going along in a very aggressive way. Don't be adventurous with AV nodal reentrant arrhythmia, because walking on ablating AV nodal arrhythmia is like walking on this track. So you have a very slow, very low safety margin. So make sure that you give a safe ablation. Don't cause AV block unnecessarily. With this, I'll close my talk. Any questions or discussion, I'll be happy to be part of it. Thank you.
Well, Lawrence, I think you are done.